I'll spare the lawyers. I'll ask questions to the clinicians. Just one little question to Seb first, and the comment for Kiran. First of all, Seb, very interesting presentation on PCS, a term which I don't believe in. But interestingly, there's a fantastic overview of PCS that I've come across in a very well-known scientific journal called Wikipedia. I truly go and check out Wikipedia. It's a fantastic, and it's got a very good list of references. What I wanted to ask you, you mentioned about some of the factors which maintain the symptoms following PCS, the term I don't believe in. And one of them, which you thought is quite important, is the psychological perception. Is this equivalent to what we psychiatrists call illness behavior?
It depends on what you mean by illness behavior.
Okay.
I think there's some interesting aspects, again, to do with kind of maybe avoidance of kind of certain sort of situations because of concerns about maybe exacerbating kind of symptoms, but also I think the extent to which people maybe avoid putting themselves into cognitively challenging situations because they are concerned it would simply highlight their own cognitive inefficiencies, or they won't be able to kind of to think as quickly or as sharply as they would have done before. So I suppose that, yes, there are probably some overlaps between the cognitions and behaviour, because that's generally what we would probably expect to see. So yes.
Yeah, I don't know exactly how to define illness behaviour, but broadly we understand that even in the litigation context where you feel it's all to do with money, but it's probably something else beyond money. It's just that they're so cozy in that role as a disabled person. And there's this underlying gain of some kind. So it's not overt like I'm doing it for money, but it's somehow subconscious that they're so used to that role they don't want to come out of it, and there's some secondary gains or whatever from it.
Yeah, certainly in terms of this notion of compensation neurosis, it's a kind of a term that sort of you don't really see written about or discussed, but there was, again, quite a nice kind of study from, I think, the mid-90s about sort of, there was an association between overprotective relatives and persistent kind of difficulties, again, in people who had ongoing sort of medical legal kind of claims. So, yeah.
I'll skip the second comment. I'll let others chip in.
Could I just ask you to comment in relation to the cohort of the patient population, what the range of capacity was and how that was assessed?
They all had capacity.
Say again?
They all had capacity. We assume they had capacity because essentially they had less severe injuries. We weren't particularly concerned that they had significant cognitive difficulties. Okay. So we made that assumption.
Okay, so there was no test, it was just assumed?
Yep.
Okay.
Hi, it's Dr. Ivan Pittman. I'm a psychologist with the Brain Injury Rehab Trust and a long-standing interest in crime and brain injury. And I was just wondering if any of the panel really want to comment on the high prevalence rates that we're finding within prisons regarding brain injury, not in terms of severity, but what we're actually finding is repetitive mild and accumulative effects of repetitive mild brain injury among the criminal fraternity.
I'll have a
You've got the microphone.
For my money, I think there's a lot of interesting kind of work going on around sort of repetitive mild TBI and the extent to which it sets up risks for later on in life, and the chronic traumatic encephalopathy argument. I know I've had a chat with Hugh Williams about this kind of, and I think Hugh probably can fall slightly kind of more on the other side of the fence. I'd be kind of interested to know more about the context in which people are having repetitive mild head injuries, and whether it's maybe an indicator for other psychosocial kind of factors that may be also kind of associated with kind of other kind of risk factors in terms of offending. So whether it's kind of it's one of those sort of classic kind of traumatic brain injury, chicken and egg, or is it simply a common correlate? Really hard to do the research. Yeah. But I think I'm probably still on the sceptical side of things when it comes to that. I don't know if anyone wants to have a...
Hilary, do you want to come in there?
Only to say from my experience with a couple of cases involving claimants who have had absolutely horrific pre-injury lives, teasing out the difference between and the cause of what we are now seeing is nigh on impossible, I would expect, both from a neuropsychiatric and neuropsychological perspective. And I think the influence particularly of drug and alcohol abuse post-brain injury, as we would all know from the work that we do and the work that you do, adds a huge factor of complication to identifying exactly what is what. In 2 cases I can think of where there is a very high risk of repeat offending behaviour. We are liaising, working closely with the police all the time, and with the support networks that those clients have, but actually breaking that pattern and then getting the evidence to tease out what is caused by what and how best also to treat and rehabilitate those individuals is a really big challenge.
So you agree, Dr. O'Driscoll? Do you want to...
Well, this is entirely anecdotal, but the prison officers seem to be able to tell individuals who are not right. So,
technical term.
whether head injury goes with the territory of risk taking, but they certainly anyone who's been affected by a significant brain injury, the prison officers seem to be able to tell whether they fit in or not, and we'll bring that to your attention.
Is that all right? Anything further? Do you want a second go?
No, not the second question. Is in relation to what you just said about the prison population. It's just to say that your average TBI patient is not a representation of your average general population. They have certain characteristics. They come from low socioeconomic background by and large. I'm not generalizing, but it's the research findings. They have certain personality traits. They take risks. Some of them had this undiagnosed, untreated ADHD you have heard about before. And some are on drug and alcohol and other things. So when you talk about patient population, and some have low IQ-ish types. So it's probably not surprising to see a higher proportion of people in the prison having had a history of head injury because of those traits, perhaps.
Do you want to come back on that? Seemed like a bit of contention at the end of the day.
So yeah, part of the research we carried out at HMP Leeds just really highlighted it's the recidivism rates that were key. So it's the number of individuals that were going out of prison and then quickly coming back in again. And really part of the issues around the brain injury is the failure, as we're highlighting, the impulsivity, the failure to learn, the social aspects of things, and how there's a lack of appreciation within the legal context and the probation and so on in terms of them being able to recognise these individuals, their vulnerabilities that they presented, and so these guys rapidly went back to kind of their habitual ways of being, really.
Okay.
If I could
Mr. McGee?
definitely pick up on that, what I was going to say is that one of the issues here is, should we say, the ability of the legal profession and the professionals to be able to perhaps think a little bit more laterally and appreciate that perhaps the reason why certain individuals are doing certain things has a medical cause, or so it's related, and perhaps seek that out, which at the end of the day is going to assist their client, but also, more importantly, assist the people who, at the end of the day, are going to be the right people to try and help them out. It's a knowledge issue, which, if I'm going to get on my platform now, is clearly going to get worse within the context of all the relevant cuts, etc., that are going to take place. But that's the way it is.
I think it was once usefully described. I think Mark and I were delivering at a session, and there was a healthcare professional that was delivering before us, and he described that he lived on Planet Healthcare, and that in Planet Healthcare things are not as clear-cut as maybe they are in the legal world, and that lawyers live on Planet Law and healthcare professionals live on Planet Healthcare. So I think what he's really saying is that we live on another planet, but in real terms, what he was saying is sometimes when those worlds collide, yeah, they don't quite see eye to eye because they don't have the level of insight and understanding, if that assists. Anything further? Because I'm conscious that we are going to finish at 10:02. Dr. Elman-Amir, was there something at the back?
No.
No? You were just covering your options, Kim, yeah?
Just covering all bases.
I would just like to ask about the capacity assessment and its limitation within a brain injured individual, where they will have deeply some very explicit change in their personality that they can easily take all the boxes as having full capacity to, for example, to manage their own finance or a huge sum of money after compensation. But you know that this is so different and so reckless compared to how they were before, but legally they are okay.
Yeah, that's your next conference, Doctor, to discuss that. Dr. O'Driscoll?
It's one of the most contentious issues, is trying to convince the courts that there is a discrepancy between a laboratory assessment of capacity and the real world. And the most common answer you get, and allegedly I found out because I was heavily criticised by a neuropsychologist who will remain nameless, who said I hadn't asked the right questions. And when I wrote back and asked what the right questions were, I didn't get a reply. But the gist of it is, what she was saying is, have you asked him what he'd do with his 200 grand or whatever he gets from the course? And the classical answer is, I would buy a house. But you know from the individuals you see that them walking down the street, they will put their hand in their pocket and give their money to someone who happens to be begging because they're stimulus bound. But people who are not used to the real world contrast with the laboratory setting fall for that. And I think that's extremely difficult. Although, to be fair, the courts, I think, are beginning to get wise up to this. And certainly recent rulings, they have actually mentioned the word real world as opposed to laboratory assessments.
But that, in part, needs to be drawn out because in some jurisdictions, the courts are getting those issues. In other jurisdictions, they're not. And that's part of a way of trying to educate the judiciary.
So what is the advice then, if when you are asked to assess capacity, especially in this particular issue, financial management, and if you go through the full criteria of capacity assessment, people would do that quite easily, but you know that there will be a huge problem.
There's a Supreme Court decision called Re-G, which is 2011, which is, in my respectful submission, the leading case on capacity in this Lady Justice Hale. Yeah? And it's a criminal case, believe it or not, but it's a case that civil practitioners that they don't seem to know about. And what it basically says, it potentially assists you in relation to your point. Yeah? In that it picks up Doug's point, which is the real world point, which is that if you look at the criteria set out in Section 1 of the Mental Capacity Act or whatever, then on the face of it, it may be satisfied, but you have to look at the decision in context, in the sense of the individual within their environment. Yeah? That case was about whether or not an individual could give consent to sexual relations. Yeah? And basically what Lady Justice Hale says is that is in this particular, it's issue specific, it's also context specific, and you have to look at the individual. Yeah. The other point as well for you to bear in mind is that at the end of the day, you're one piece in the cog in terms of giving your view. Yeah. You're perfectly entitled to set out what your views are on capacity, having regard to your interpretation of the relevant section. Yeah? The person who makes the decision, or the individual who makes the decision, if needs be, is the judge. And again, coming back to some recent decisions, very, very recent decision where two psychiatrists, where a woman coming close to the 24-week time limit for a termination, suffering from bipolar affective disorder, she's sectioned, yeah, and two psychiatrists, an expert, and the responsible clinician say no, she hasn't got capacity. Goes to court, they give evidence, she gives evidence, judge says she has got capacity. Now that's in a different context, but the point there is you're only one person within the court. You're perfectly entitled to set out your full reasons as to why, in your view, the person doesn't have capacity. Yeah. But again, there is assistance within the context of the case law. Yeah.
If I could summarise it, it's best summarised by Baroness Hale, where she says psychiatry is not an exact science. It's an uncertain branch of medical practice. Yeah, that's not having a go, it's just highlighting the complexity of the issues. And on that note, I'm going to draw it to a close, other than to invite Dr. El Namir to do some final closing comments.